pleasure then that I've been asked to introduce Aimee Middlemiss, who I had the pleasure of supervising. And I supervised Aimee's doctorate with Susan Kelly. So it is absolutely appropriate that we are here in the Susan Kelly seminar room to engage with Aimee's most recent work. Now, her thesis was published as a book by Bergan, and it was entitled Invisible Labours, The Reproductive Politics of Second Trimester Pregnancy Loss in England, published by Bergan, as I said. I also want to tell you a bit about what Aimee is now currently doing. She's a research fellow at the Centre for Cultures and Environments of Health, where she holds a Wellcome Early Career Award that explores the politics of the cervical stitch, which I understand you're going to talk a bit about today. And in talking about that aspect of her work, she's also going to draw upon some work from a research fellowship at the University of Plymouth that looked at the NHS's implementation of Midwifery Continuity of Carer, which is a workforce model, and you're going to bring that together with the surgical stitch work today and get us thinking about what's going on in the NHS vis-a-vis reproduction and maternity care. So without further ado, I hand over to Aimee.
Thank you very much, Catherine. So actually, Catherine covered loads of my early stuff there. I'll move on quickly. It's really nice to be back here at Egenis though and doing this with all of you. The talk has shifted a little bit from the abstract, so I wrote it a while ago, so bear with me, but hopefully it will all make sense for you. As Catherine has just said, the postdoc I'm going to be drawing on first today was the University of Plymouth project with PI Professor Alan Jones, and it was an NIHR funded project involving several other universities and organisations. And I'm going to spend a bit of time talking about this and a specific part of the findings about moral and truth regimes. Then I'm going to connect to a major NHS England maternity policy, and that also then leads us into my current research on cervical cerclage, cervical stitch. So, first of all though, I'm going to start with the context of this whole talk, which is the poor state of the UK and specifically England's maternity services. And some of you are probably already aware of this, but there have been repeated reports about an ongoing crisis in maternity care and in maternity outcomes for over a decade. So there were reports by Bill Kirkup and Donna Ockenden on care failings at Morecambe Bay in 2015, at Shrewsbury and Telford in 2020, at East Kent in 2022. There's a current investigation going on at Nottingham. There's been epidemiological surveillance done by Embrace UK that has shown disparities in care outcomes for Black and Asian women and women from socio-economically deprived backgrounds. And last year, the government announced yet another independent review by Baroness Amos into systemic safety failings in UK maternity services. There's also a general sense amongst women who've recently been pregnant that not only is the system actually unsafe for some people, it's really unpleasant, stressful, and often traumatising for many more. And that was reflected in 2024's all-party parliamentary group report on birth trauma. So besides the general and the widespread maternity care failures, there are also specific issues about outcomes for fetuses and babies. And in 2021, the UK had the 12th worst stillbirth rate out of 17 comparable countries. On top of this, preterm birth rates and stillbirth rates are higher for Black and Asian origin babies than white babies. So poor maternity experiences and outcomes are really widespread. They're especially prevalent from those from deprived and racialised minority backgrounds. NHS England has been trying to solve this and reform maternity care for some time, working from plans laid out in 2016 in the report Better Births. And keep coming back to that. So it was led by the former Conservative Health Minister, Baroness Cumberledge, and commissioned by the then Health Secretary, Jeremy Hunt. And a key reform in Better Births was seeking to improve continuity in maternity care. In the original report, this was continuity from lots of different people working with women, so including obstetricians, for example. But over time in the NHS guidance and in the implementation of the policy, it became focused on a requirement for the midwifery workforce. And the focus was the implementation of a model of care affecting the deployment of the workforce called Midwifery Continuity of Carer. And note the emphasis on the individual carer, not the care being continuous, so that the actual person needed to be the continuous element. And this was the subject of the SIMCA project at the University of Plymouth. So, Midwifery Continuity of Care is a system of maternity care organisation where the same midwife or small group of midwives provides antenatal, intrapartum and postnatal care. So the 3 phases of care. So instead of different midwives specialising, for example, in pregnancy, birth and the postnatal period, the same person is acting across it. So traditionally, in the system that was prior to this, usually community midwives in England covered the pregnancy bit and the postnatal bit. And most people, if they weren't having a home birth, would go into hospital and have specialist care from teams that specialise in birth and especially complex birth in a hospital setting. But in a midwifery continuity of care system, one person covers all of that, coming into the hospital to care for a woman in a caseload who's gone into labour or needs to deliver. So the model usually involves on-call working, managing a caseload of women, and in the 2016 Better Births report, the target was this would become the default model of care in England. And the rationale was based on the value to women of relational care, so the relationship with the midwife, but also on some clinical outcome claims in a Cochrane review from 2016 as well, which has since been degraded in 2024. I'll come back to those. So Midwifery Continuity of Carer was an attempted major reorganisation of the midwifery workforce in England, but it hasn't actually become the default model of care. And the SIMCA project, led by Plymouth, was supposed to look at the different rates of implementation progress in different trusts. But when we actually started looking at it in detail, we found there was a really patchy landscape of very little functioning midwifery continuity of care at all. So the project actually ended up looking at why the implementation of midwifery continuity of care failed to become the default model of care. And one of the biggest challenges to the service implicated in midwifery continuity of care, which I'm going to short to NCOC just so I took over my own tongue, is midwives working in an on-call way for a defined caseload of women, following them into hospital to provide birth care. And some of the reasons we found for this being difficult were that birth is temporally uncertain, a full-term pregnancy and the spontaneous onset of physiological labour can be any point between weeks 37 and 42, and a labour can be days or it can be really quick. So maternity care has these elements that are really similar to A&E in terms of workforce requirements. And hospital intrapartum care is obviously 24 hours a day, and there's a varying number of women in labour coming in at any one time. So on-call really impacts on private life when you're trying to service this system. It impacts on childcare, on travel, on housing, on health, and we've got papers under review about all these aspects. So this way of working is really difficult for some midwives to get involved in because of their personal circumstances. And it also assumes that all midwives can and should provide all elements of care. So there's not much room for specialisation, there's not even that much room for career progression. And actually, midwives do a lot more in the NHS than manage getting babies out and women. But this was supposed to be the default model of care in England, meaning 80% of care would be delivered in this way. And the reorganisation took place without any additional funding at a time when workforce overall numbers, the available midwives in the UK, were really historically low. This was partly to do with Brexit, to do with the introduction of student fees for midwifery and various other reasons that again we are publishing about. So this is what the SIMCA project was looking at, using qualitative and survey work and work in NHS case sites. But for this part of the study, which has been published in Sociology of Health and Illness, we used data from 44 stakeholders at a national level. So these were people who are really senior midwives in the NHS, people who are NHS policy people, and stakeholder organisations like the Royal College of Midwives. And during the analysis of all this data, there was a lot going on around socio-cultural and personal values. And there was also a lot about evidence and advantage claims related to midwifery continuity of care. And I'd already led on a literature review of midwifery continuity of care implementation research that showed that evidence was often used to support claims about the model in a way that exceeded the evidence base. So we brought this together and interpreted the data through coding concepts of truth and moral regimes. So we connected regimes of truth regarding what counts as a truth, who can produce and verify truth, and the political parameters around speaking a truth, with the concept of moral regimes, which is an extension of that, as descriptions of how discursive parameters come about through moral authority and how they're situated in discourse rather than hierarchical or institutional control structures. And moral regimes have been located by other people in ethical rather than epistemological politics. But we argue that in midwifery continuity of care implementation, moral regimes and regimes of truth are intertwined, and knowledge is intimately connected to morality. And I'm going to illustrate a bit using some of our data. So in the analysis of our interviews with stakeholders on the implementation of midwifery continuity of care, we found really specific and strongly held positions on the nature of the intervention, its value and moral status, how this should be communicated to other people, including through the use of evidence, and the characteristics of supporters and dissenters as ethical and moral persons. So midwifery continuity of care was positioned as an ideal form of maternity care with ethical and moral underpinning, and it was often invoked as the solution to lots and lots of different issues in maternity care, including maternity safety and quality, women's autonomy and choice, personalised care, birth trauma, over-medicalisation, health outcome for babies, and health inequality. And it was repeatedly referred to by loads of people as gold standard of care, or the magic formula, as this pure, true, real form of midwifery. And arguments about implementing this form of care partly rested on moral obligation and the deservingness of pregnant women, especially those who are construed as particularly needy, such as deprived women and racialised women who have the worst maternity outcomes. So there was a lot of this kind of rhetoric about midwives are supposed to be caring, but it's unethical not to do it. It's the best evidence base. It's absolute responsibility to do this gold standard of care. But the need to persuade other people to participate in implementation also meant that other values were invoked in this participation. And using this term gold standard was a claim connecting midwifery continuity of care to the dominant values of medicine, expressed through evidence-based clinical outcomes, commonly referred to as the gold standard of evidence. And it's not a coincidence that the Cochrane reviews are positioned in this space. And one of those was the main evidence in 2016 for the efficacy of midwifery continuity of care in terms of outcome, until it was recently downgraded. And it's also significant that claims about evidence were rhetorically connected to gold standard clinical evidence, when medicine is socially and politically positioned as more authoritative than midwifery. At the same time, the midwifery professionals were locating this type of care in their own special relationship with women, which is often sort of one where midwifery is more aligned with women, and obstetricians and the medical profession are slightly separate from what women would want. And that has a very strong moral overtone to it. So this was just an example of illustrating that, really, that they were an event and the obstetrician said we might as well give up on continuity of carer, and somebody said, do you not believe women are entitled to the gold standard of care? And there was a lot of this kind of positioning. So a key factor in the implementation process was the need to persuade and convert other people to this model of care. And persuasion was based on very strong advantage claims to the model of care supported by this 2016 Cochrane review. And this was namely a hugely reduced risk of preterm birth, neonatal death, and pre-24-week fetal loss, and the reduction in the use of epidural pain control and forceps deliveries if you had midwifery continuity of carer. And there's a whole load of questions that you can ask about that generally. I won't go into them because it's a bit too detailed. But the review was updated 2 years ago now, and almost all of those gains have been lost in the updated version. So, I mean, at one point they were saying something like 20% of baby deaths can be averted with this model of care, and now that's completely gone. But until last year, NHS England were really heavily relying on this Cochrane review as evidence, as the gold standard evidence, to persuade people to implement midwifery continuity of carer. So it was the best evidence for the best care. And what this did was it meant that people who were critical of the implementation, was actually really hard to do with limited midwives and limited resources, Or those people who question the plausibility of the Cochrane Review's big claims were branded as naysayers, as difficult, as insufficiently committed, or as ignorant of the message and the evidence. And the whole implementation became extremely polarised and contentious. So we had these sort of quotes, people being branded as a poor leader. You couldn't talk about it at all because everybody just wanted to do this one mission. So, besides the clinical outcome arguments used to implement continuity of care, there's a big connection between the model of midwifery professional values. And often the vocational history of midwifery was invoked. Its professional origins, its ethos of being with women, midwifery, and being of service to women, which you can see in some of these quotes here. So those midwives who couldn't or wouldn't participate in midwifery continuity of care with its grueling on-call schedules, which disrupt personal life, could be represented as inadequate professionals, as uncommitted and not willing to go the extra mile, and not willing to put in the discretionary effort that would prove their worth as midwives. So the failure of a local and national implementation project became personal or moral failure rather than a more complex systemic process. So overall, we identified a moral regime in the attempted implementation of midwifery continuity of care, where the model of care was imbued with intrinsic and special value aligned with the best care, so it became imperative to participate, which meant there was a vocational responsibility of midwives to put in discretionary effort and to spread the word to others in the form of evangelism. At the same time, the alignment with professional values led to limits on what could be fed in critique, and the alignment of the policy with the truth regime around the evidence of the model of care also led to limits on what could be said in critique. So apart from being a case study of specific moral regime and its impact on policy implementation in healthcare, this work also contributes to some general understandings of the operation of power in national healthcare systems. So we know from other people such as Bartosz et al. That moral values underpin health systems, but we've shown that they're essentially used during change processes and during improvement processes. So moral regimes are not static universal values, but they're dynamic, active and contested political processes within health systems. And they can be brought alongside truth regimes to strengthen arguments in the politics of healthcare improvement. So moral values that align closely with professional values produce a strong and motivating and very coherent, internally, moral regime which can be used to try and affect behaviour in healthcare settings. But at the same time, if you've got this moral regime, you can end up with further political ramifications when counter-arguments become unsayable in a tightly prescribed moral regime, which is also coterminous with the truth regime. So in the case of midwifery continuity of care, this probably actually impeded implementation success because it wasn't paying attention to conditions on the ground. And we argued in our paper that tracing moral regimes in healthcare alongside truth regimes can offer insight into the role of sociocultural values in the politics of healthcare and the possibilities and limitations of agency in healthcare systems. So that's the first section. I'm now going to draw some of these threads into a new project that I'm working on by way of former Health Secretary Jeremy Hunt up there and his ambitions for NHS maternity care when he was in the role from 2012 to 2018, and also some maternity care policies that originated in that period. So looking back to those maternity scandals that were happening more than 10 years ago, Jeremy Hunt asked Baroness Cumberledge to report on maternity safety, a bit like Baroness Amos is doing now, and she came up with the 2016 National Maternity Review and the Better Births Report, and that, as we've seen, included midwifery continuity of care as a key plank. And it reported at the same time as the 2016 Cochrane Review, and a lot of these people are quite connected, though the people that were on the Cochrane Review are also very connected to NHS England, for example. And that Cochrane Review showed enormous, and I would argue implausible, effects of the model of care on reducing stillbirth and neonatal loss specifically. So this key plank status meant that midwifery continuity of care also travelled into other NHS policy. And the SIMCA project have got another paper under review about the extent of that. And there are connections here with other work from social science and medicine about the role of morality in healthcare. including Davis 2025 on the moral force guidelines. One influential policy that eventually came to adopt midwifery continuity of carer as a recommendation was NHS England's Saving Babies' Lives Care Bundle, first introduced again in 2016 as part of the response to better births, and after Jeremy Hunt pledged to halve stillbirth by 2030 and reduce it by 20% by 2020, as well as reducing maternal deaths. So Hunt was responding to epidemiological surveillance by Embrace UK in 2015 that found that 6 out of 10 stillbirths could have potentially been avoided. And as well as the maternity safety background for poor outcomes for women and babies, it's also likely he was responding to his strong personal moral interest in fetal life. So Hunt is a practicing Christian, and he's consistently voted in Parliament to reduce the abortion gestational age threshold. He also commissioned the Pregnancy Loss Review in 2018, the remit of which was partly to look at the feasibility of introducing birth registration for deaths before viability. So not stillbirths, but earlier pregnancy loss. And I've written about that as part of my book on pre-viability pregnancy loss. So Jeremy Hunt has a record of acting in the prenatal space and supporting policies that align with the possibility of increased legal status for fetal beings. And these policies align with according moral status of the fetus and understanding it as an important patient in NHS maternity. So you can see that the progression of claims, evidence, and policies in this list is in relation to reaction to problems that present themselves through evidence and then require a response for moral reasons. And the response then also draws in more evidence as justification for how to act and who should act. So in 2015, we had the Kirkhope report and some CQC Care Quality Commission ratings saying maternity care safety is a problem. And Hunt said, well, the government needs to act, so he commissioned the National Maternity Review that resulted in better births. Also in 2015, Embrace said stillbirth is a problem because it's worse in some areas than others. And Hunt said the government needs to act, and he declared these targets on stillbirth reduction. In 2016, the Better Births report said that maternity care safety can be solved by moving to midwifery continuity of carer, and it has some other less significant elements such as rethinking funding and improving choice for women that are kind of classic conservative approaches to health. In 2016, the Cochrane review said midwifery continuity of carer can dramatically reduce stillbirth and neonatal loss, and we've already seen this is a big interest of Jeremy Hunt. And then in 2016, the Department of Health, led by Jeremy Hunt, laid out how this can all be the work of NHS England, which is the body set up in 2012 to commission services from local NHS providers under the direction of the government. So you can also see how the target of policy action shifted during this period, from overall maternity safety to stillbirth, back to overall maternity safety, then to include neonatal death and brain injury and maternal deaths as this progressed. And evidence was implicated in defining what should and could and should be acted on. For example, the Cochrane review of midwifery continuity of carer brought together stillbirth and neonatal loss, or Embrace focused on stillbirth regional disparities despite the declining overall rate. So then in 2016, we get to the first Saving Babies' Lives policy. And this was produced by NHS England because of that demand by Jeremy Hunt's Department of Health. And it contained recommendations for clinical care. And the original Saving Babies' Lives document was entirely focused on reducing stillbirth, which is obviously Jeremy Hunt's target. Its production brought together all the great and good with a stake in maternity services. And the document has got forewords from NHS England, the Royal College of Midwives, the Royal College of Obstetricians and Gynecologists, the British Maternal Fetal Medicine Society, Embrace UK, the Baby Loss Charity SANS. And they're all describing in these forewords the need for action in this area. And the key areas of clinical action for the first Saving Babies' Lives document were smoking cessation, fetal growth monitoring, awareness of reduced fetal movement during pregnancy, and better fetal monitoring in labour. And all of those things are trying to address this core problem of not spotting fetal distress or poor fetal growth. So they're trying to act on factors that are considered to foretell stillbirth. In version 1 of Saving Babies' Lives, you can pick out themes of morality, truth, and connections between them, starting with the emotive title. So this isn't a policy that you're going to very easily cancel. The moral imperative to save babies is not going away anytime soon. And we're not saving fetuses here. These are babies from the outset. And there's a connection in terms of this idea of saving babies to recent social science work on saving babies. In the US context, Davis has written about the differential saving of preterm black babies compared to white babies in the US. Casper has written about US action on infant mortality being connected to biopolitics, eugenics, and race in relation to which babies are saved. Kramer has written about US evangelicals saving discarded frozen embryos by implanting them in their own bodies, again with eugenics and race overturns. And in the UK, Fessus and Jackson have written about decisions not to treat babies born at the margins of viability at 24 weeks, around 24 weeks, again with connections to eugenic reasoning. And in Europe, Van der Waal last year discussed the use of the dead baby card in ensuring women's compliance with obstetric policy. So stepping back to the first Save Babies' Lives policy, the multiple forwards to this policy show how much everyone wants to be associated with saving these babies, and many invoke moral arguments related to acting in this area, the tragedy of stillbirth, the need to help families, or moral behaviours to be associated with the action, the vital need for action, collaborative working. At the same time, there's an awareness from the medical contributors that the evidence for how to save the baby's lives is not as robust as they would like. So Matthew Dolly, National Clinical Director for Maternity and Women's Health, NHS England, says this shouldn't preclude having a go anyway. And Jenny Karinsuk from Embrace says we can look for the supporting evidence while the things are being rolled out. So this policy entanglement of evidence with moral imperatives is reminiscent of Midwifery Continuity of Carer, where there was a truth regime around the evidence for the model of care. But this time it's a different argument. It's not we have the evidence, however implausible you might think it is, so we must act. But this is we don't really have the evidence, we must act anyway. So briefly going back to the paper on continuity of care I described earlier, saving babies' lives seems to suggest that moral regimes in healthcare can trump regimes of truth, and that a verified evidence-based truth in obstetric medicine is less central than moral action on the tragedy of stillbirth. But it's perhaps also really notable that the people who can speak this further truth here are those at the top of their profession, and they're drawing on institutional power as well as discursive power. So, I'm still only about partway through this. In 2019, a new iteration of Saving Babies' Lives was introduced, version 2. And this represented a significant shift in the policy. It was subheaded Care Bundle for Reducing Perinatal Mortality, instead of subheaded with the aim to reduce stillbirth, which is just fetal death after 24 weeks. So the idea of perinatal mortality connects preterm birth, neonatal death, and pre-24-week fetal loss. It discursively situates all babies and fetal beings and their deaths potentially equivalent. That question of which babies are saved is back again, and now includes all fetuses as well. It produces all of them as targets for NHS action, and this is really significantly different from the first Saving Babies' Lives focused on stillbirth and neonatal loss, because now pre-viability fetuses are includable. Remember Jeremy Hunt's interest in fetal life. And that idea dovetails with other areas of guidance. For example, RCOG advice on managing extreme preterm birth in 2020 stated that people should actively intervene from 22 weeks gestation, which is 2 weeks prior to legal viability. And there is an NHS requirement to report neonatal deaths from 20 weeks of pregnancy to Embrace, which is 4 weeks prior to legal viability. So I argue that this is a breaching by biomedicine and policy of legal thresholds related to fetal status, and this was already all noted in my previous work on second trimester pregnancy loss. Hang on. No, hang on. Sorry, I lost my space. So the key new change in Saving Babies' Lives version 2, which moves it to perinatal mortality, is the introduction of a fifth element to the policy. So we had smoking, fetal growth monitoring, fetal movement awareness, fetal monitoring in labour, and they're all about stillbirth. And the fifth one is reducing preterm birth altogether. This means birth before 37 weeks of a pregnancy, which should last about 40 weeks. So this element is seeking to act on neonatal mortality, i.e. birth and then death outside the uterus, which is the birth and death of a legal person. But it also retains this discursive connection to stillbirth, which is not the death of a legal person, and now also to pre-24-week loss through the use of this term perinatal mortality. So this fifth element in Saving Babies' Lives version 2, the action on preterm birth, is explained in the document as necessary because according to Embrace, most stillbirth and neonatal deaths occur in preterm or extremely preterm fetuses and babies. But inclusion of this area actually extends the Saving Babies' Lives policy even further because it's now acting not just on the mortality of babies and fetuses, but also on morbidity. And it's adding in a whole new field of action, which is not actually mentioned in the policy title, which is morbidity in relation to the future living person. The future quality of life of the fetus who will be a future person, a citizen, a user of education, and of NHS healthcare. And there are moral and eugenic overtones here about which lives are worth preserving and why and who gets to decide. And these could actually come into conflict with the interest in preserving all fetal life, which we've seen with Jeremy Hunt's time as Health Secretary. So adding action on preterm birth substantially changed this policy in a practical sense as well. It added new action on the prediction and prevention of preterm birth, including diagnostics such as access to transvaginal cervical scans, clinical interventions such as aspirin and cervical cerclage, both of which I'm going to come on shortly, and actions such as optimising the birth location for neonatal care when there's going to be a preterm birth. So Saving Babies' Lives also became an intervention in the structure of maternity departments, for example, requiring a clinician with an interest in preterm birth prevention in every department, requiring a clinical pathway for women at risk of preterm birth, and a referral pathway to tertiary clinics or places where they could get cerclage or the cervical stitch, which I'm coming to. And the policy also connects to the maternity incentive scheme, which refunds insurance premium money to NHS trusts when they can evidence that they're implementing Saving Babies' Lives and some other safety actions. So there's this carrot and stick incentive to engage with the policy. And you can see why this might happen because, for example, in the news last week, the NHS was found liable for lifetime costs of disability caused by birth injury. So interestingly, on top of the mandated preterm birth elements, Saving Babies' Lives now includes other things which are recommended rather than mandatory, including our old friend Midwifery Continuity of Carer. So that's now plunked in there as well. So the development of Saving Babies' Lives is an example of a strategic extension of a policy based in moral values, and it also has evidence and truth implications. Version 2 has another insertion from the Clinical Director of Maternity and Women's Health that effectively pathways of care will improve outcomes, even if there isn't really very strong evidence for that. And this is highly reminiscent of that 2016 Cochrane review in Midwifery Continuity of Carer. And note the introduction of the value of pragmatism. And I think this is really interesting and like my new project I'm coming on to shortly. And before I move on to my new project, I just want to note there's a third version of Saving Babies' Lives 2023, which introduces yet another element, which is about pre-existing diabetes in pregnancy. Version 3 of this of interest to me this time, because this time Matthew Jolly's again acknowledges a recent rise in the perinatal mortality rate, but discounts the significance of this. And I do wonder what he might have claimed if it had gone down. In this quote from his forward to version 3, he's still claiming success in relation to figures from 2010, which was 6 years before Saving Babies' Lives was introduced and 13 years prior to these comments. So that's his comparison point. Other forwards in version 3 warn that the 2025 target to halve stillbirths and neonatal deaths will not be met, and it wasn't, and that stillbirth rates actually rose in 2021. It's also interesting that in most of the forwards of version 3, there's a strong emphasis on the social determinants of health and on health equity, especially for racialised and deprived groups. And incidentally, after the failure of the mass implementation of continuity of carer, there's a renewed emphasis on using it for those targeted groups. And it seems to me that when evidence is going the wrong way for the general population, interventions are still seen as valuable for racialised and deprived groups. And I find it problematic that the solution to differential outcomes is to throw more of the same evidence-lacking policies at saving those babies. I also think it's a deliberate emphasis on the limitations of maternity care to solve wider social problems of health. It somewhat prepares the ground for not meeting any of those Jeremy Hunt targets on stillbirth, neonatal death, or perinatal mortality as a whole. So, hopefully you're still following me. What you've taken away from this is looking at in detail an intervention in the English NHS maternity services, looking at the Midwifery Continuity of Carer and the SIMCA project, showing entanglement of moral and truth regimes in attempts to implement quality improvement and address poor maternity outcomes. Stepping back to the wider policy context in which this intervention was embedded also shows moral reasoning and an attitude to evidence or truth regimes where practical action is somewhat prioritised over evidence-based medicine, which is acknowledged as limited, and where other truths, such as Matthew Jolly's best practice care, can be drawn on instead. And moral ideas of women's deservingness and the need to save babies are threaded through the policy. So, for example, the most vulnerable women and babies in terms of outcome need more of the action, even if the evidence is not really there that it will work. And the focus of improvement in maternity care has repeatedly been extended into new fields of action, including biopolitical goals such as optimising future populations and seeking to act on preterm morbidity, as well as averting fetal and neonatal morbidity. And this all brings me to my new project containing pregnancies, which is investigating the reproductive politics of the cervical stitch or cerclage in England. It's been funded by Wellcome Early Career Award. So this project looks at the obstetric procedure of the cervical stitch or cerclage, which you may remember has been promoted by Saving Babies' Lives since version 2. And the cervical stitch is a biomedical intervention aimed at prolonging pregnancy by sewing shut the cervix at the entrance to the uterus, as you can see in this image from the Royal College of Obstetricians and Gynecologists. So the general idea is to prevent the exit of the fetus from the uterus too early in pregnancy, to reduce the chances of preterm birth and therefore act on perinatal mortality and morbidity. And there are two main forms of the stitch, the transabdominal up here and the transvaginal, which is they're just different methods of putting it in basically on different heights. It can be carried out as an emergency procedure, but it's more often used prophylactically, connected to surveillance of the cervix by ultrasound, which we also saw promoted in Saving Babies' Lives. Although it requires theatre time for insertion, the transvaginal stitch can be done under spinal anaesthetic in pregnancy and it can be removed quickly. It's not considered to have long-term effects on fertility or side effects, so it's relatively low cost and relatively low risk to the pregnant woman. And it sits in a space where there's very little else to offer a pregnant woman at risk of preterm birth. It's been around since the 1950s, it's an old reproductive technology, but there's uncertainty about its optimal use in relation to outcome. Even though its outcome of efficacy is uncertain, it still forms this major part of NHS recommendations for care in individual pregnancies and at population level through NHS England's Saving Babies' Lives and through its link to funding for maternity units. So it's a technology of reproduction that's trying to act on the fetal body through the pregnant body to prevent the fetal being emerging to as good chance of surviving, preferably with minimal disability, at which point if it's born alive, it will be a legal person and a citizen. So my work is a multi-sited ethnography framed by reproductive governance theory as developed by Morgan and Roberts. And using their definition, it will be looking at the mechanisms through which different historically situated configurations of actors use legislative controls, economic inducements, moral injunctions, direct coercion and ethical incitements to produce, monitor and control reproductive behaviours and practices. So reproductive governance has mostly been used, including by me in previous work, to look at reproducing subjects and the way that they are governed and their subjectivities come about. But I'm also interested in thinking about how healthcare actors and others are subject to reproductive governance around preterm birth and tracing where this comes from and the effects that it has. For example, the Saving Babies' Lives requirements to have a preterm birth specialist and an established route to accessing the cervical stitch, and to provide transvaginal ultrasound monitoring, which can be a route to somebody being entitled to receive the stitch. And to have the stitch in their obstetric offer despite the lack of trial evidence, for example, for its efficacy and the lack of biomedical knowledge about why preterm birth happens at all. And the logic of never being able to know if getting a specific pregnancy to term was down to the stitch or for some other reason. So the project will also draw on biopolitics and ontological politics regarding the status of the fetal being in relation to personhood and patienthood. Thinking about what's happening when the stitch is positioned as a way of saving babies' lives, and whether maternity services are acting on a living subject's fertility or on an ambiguously positioned fetal subject and its future potential. So the plan is to analyse policy and other documents, to interview stakeholders at national level, like guideline authors and training providers and third sector organisations, to interview people who've got experience of the stitch in their reproductive life, and to do fieldwork in the NHS, in which I'm understanding the NHS as one overall site, but locating my engagement across 7 different units of maternity units. So this will include interviews with staff whose professional work involves the stitch, such as obstetricians, midwives, sonographers, and anaesthetists, hopefully some observation of preterm birth clinics, and interviews with some patients to supplement interviews in work package 3. So questions arise here from earlier in the talk. Is a moral regime identifiable in relation to the cervical stitch? What can we learn from the mission creep of saving babies' life about any moral regime? The Saving Babies' Lives show that the cervical stitch is an example of Matthew Jolly's best practice care rather than evidence-based medicine. And is this affected by the moral status of the fetus as a putative baby and person? How does this fit with the professional values of those who perform the stitch? Is there a treatment imperative in preterm birth, perhaps pressures coming from patients themselves? And how does that affect clinicians' decision-making around risk in this area? And is Matthew Jolly's pragmatism at work here? Is this stitch cheap, relatively easy, and perhaps quite an easy thing to explain conceptually to patients? And are there wider implications for reproductive politics and the policies which promote the stitch? For example, the gradual erosion of legal thresholds for personhood, which were actually set by Parliament. So that's basically me set for the next 3 years. Thank you for having me, and I would be very interested to hear all your thoughts. Break me.